Greetings. The following is a summary of the Pain Management Task Force recommendations pertaining to the CDC Guidelines. 2016 CDC Guidelines. The initial purpose was well intended for primary care physicians as a guide to treating chronic pain, provides useful general guidance, was originally supported by many organizations, but important limitations exist, including expert selection for creation of guideline, evidence inclusion criteria, method of evidence quality grading, support of recommendations with low quality evidence, instances of vague recommendations, lack of clinical trials with more than 1 year duration was used as a lack of evidence for effectiveness of opioids. Further studies are needed due to much variability in patients and conditions. Gaps plus misinterpretation and misapplication have led to unintended consequences. At least 28 states have enacted legislation, and many implemented the guideline without recognizing the target audience was meant for primary care physicians. Major unintended consequence is that patients with chronic pain on stable long-term doses of opioids have led to forced tapering and patient abandonment. In essence, clinicians should be able to use their clinical judgment to determine opioid duration for their patients. Update 1. A lack of high-quality data exists for duration of effectiveness of opioids for chronic pain. This has been interpreted as a lack of benefit. Recommendation: support studies for long-term efficacy in chronic pain syndromes in different populations determined by clinical, context, conditions, and comorbidities. Recommendation B: focusing on variability and response to tissue injury for effectiveness of opioids. Conduct clinical trials for disease-specific entities. Trials need to be real-world applicable. Update 2. Absence of criteria for identifying patients for whom opioids make up a significant part of their pain management protocol. Recommendation: conduct clinical trials or reviews to identify which subpopulations of patients may be appropriate for long-term opioid treatment in conjunction with various non-opioid modalities. 3. Emphasize or expand. Wide variation in factors that affect optimal dose of opioids. Recommendations: consider patient variables before initiation of opioid therapy, including respiratory compromise, patient metabolic variables, differences in opioid medications that affect plasma concentrations. B. Perform comprehensive initial assessments with understanding of need for comprehensive reevaluations to adjust dose. C. Give careful consideration to patients on opioid pain regimen with additional risk factors for opioid use disorder. 4. Emphasize or expand. Specific guidelines for opioid tapering and escalation need to be further clarified. Recommendations: A. A thorough assessment of risk-benefit ratio should occur whenever tapering or escalating dose. This should include collaboration with patient whenever possible. B. Develop taper or dose escalation guidelines for subpopulations of pain patients that includes consideration of their comorbidities. When benefit outweighs the risk, consider maintaining therapy for stable patients on long-term opioid therapy. 5. Emphasize or expand. Causes of worsening pain are not often recognized or considered. Non-tolerance related factors, surgery, flares, increased demands, or emotional distress. Recommendations: avoid increase in dose in stable patient until patient is reevaluated for underlying cause of elevated pain or possible opioid use disorder risk. B. Considerations to avoid dose escalation include opioid rotation, non opioid medication, interventional strategies, cognitive behavioral strategies, complementary and integrative health approaches, and physical therapy. 6. Emphasize or expand. In patients with chronic pain and anxiety or spasticity, benzodiazepine co-prescribed with opioids still have clinical value, although the risk of overdose is well established. Recommendations. When clinically indicated, co-prescription should be managed by specialists who have knowledge, training, and experience with co-prescribing. When co-prescribed for anxiety or SUD, collaboration with mental health should be considered. B. Develop clinical practice guidelines focused on tapering for co-prescription of benzos and opioids. 7. Emphasize or expand. The risk-benefit balance varies for individual patients. Doses higher than 90 mmE may be favorable for some, where doses below 90 mmE may be for other patients due to individual patient factors. Variability in effectiveness and safety between high and low doses of opioids are not clearly defined. Clinicians should use caution with higher doses in general. Recommendations. A. Using carefully monitored trial with frequent monitoring with each dose adjustment and regular risk assessment, physicians should individualize doses using lowest effective opioid dose that balances benefit, risk, and adverse reactions. B. Many factors influence benefit and risk, therefore guidance of dose should not be applied as a strict limit. Use established and measurable goals, functionality, ADL, and quality of life. 8. Emphasize or expand. Duration of pain following acute and severely painful event is widely variable. Recommendations. Appropriate duration is best considered within guidelines, but is ultimately determined by the treating clinician. CDC recommendation for duration should be emphasized as guidance only, with individualized patient care as the goal. B. Develop acute pain management guidelines for common surgical procedures and traumas. C. To address variability and provide easy solution, consideration should be given to partial refill system. At this point, we highly recommend that every pain patient, family member, caregiver, and medical professional take immediate action by submitting your comments to the Pain Management Task Force draft report on the federal docket. Please visit painwarriorsunite.com for tips and instructions on how to submit your comment. The deadline is April 1st of 2019, after which the Pain Management Task Force will submit their final report to Congress, which will ultimately become our national pain policy. Thank you for watching and have a wonderful low pain day.